Um, well, Farzad, thank you for joining. I know the precipitous for this conversation, precipitous is the right word. I'm not questioning that, but we'll keep going as if it is. Was the announcement y'all had late last year about the $500 million credit facility for Aledade. I thought it'd be fun to kick off conversation focused on that topic specifically, and then kind of go out a little bit in terms of scope, thinking about value-based care more broadly over the next 30 minutes. So if you would indulge me, I'd love to start thinking about that $500 million round and understanding logic behind it, how you guys are thinking about it. We saw earlier in the fall the great results y'all published from the MSSP program in 2024 and the savings y'all are generating. And then we saw the $500 million credit facility. And I'd love to hear your perspective on why you need such a large credit facility, what's behind that. Like, we don't
Yeah.
hear a lot about credit facilities in the startup community. And if you're, sitting down for coffee with a primary care doc in the Aledade network, and they ask you, what's up with the credit facility? How do you talk about that with them? What's the rationale behind it?
Yeah. So value-based care and kind of the ACO model in particular has a lag between when we do the work and when we get paid. So we will sign up a practice August. We'll work with them to get them on the platform. Performance year starts in January. We work all from January to December 31st. Then the year's leaf turns over. Medicare waits for all the claims to come through. They calculate, the trend and compare it. And by the time we get the check, so we just got a check for $788 million. That's work that started more than 2 years ago. And so if you think about a rapidly growing business where our receivables went from like 350 to 540 to 780, right? The $780 million check that we got is the cash that was the work that we did for the past 2 years. And so there's a working capital disjunction, which is really problematic, actually, for groups that don't have the ability to access that sort of capital. And if you're thinking policy, one of the clear policy recommendations that we have had is for CMS to give some more upfront payments for successful groups that are going to get savings and give them a portion of what you're really confident they're going to get. But absent that sort of policy change, we have to fund that timing gap. And so the credit facility, we used to have a $250 million credit facility for this purpose with a bunch of banks. And now we've kind of stepped up into 500, and it can expand further with these partners. So it's just simply to fix the timing lag between when we and the practices do the work and when we get paid.
Yep. So conceptually, it's not funding core operations. It's not
Correct.
related to that part of the business. It is back to that policy recommendation you had in there. It's essentially you guys trying to implement that on your own.
That's right.
And so going forward, does that mean, like, how does the upfront payment, like, how do you think about that upfront payment actually working going forward? Is the 500 million going to fund, the next 12 months? And how do you think about that for primary care practices in the group?
Yeah, I think it allows us not to have to charge primary care practices. When we started the business, we were like, you know what, just pay us $1 PMPM. And a lot of practices were like, I don't know, I don't have the cash flow to be able to pay for this. And now, if in fact, with many practices we're now able, if we have confidence in their savings, we're able to actually front them some of the savings that they're going to earn. So I think what it means is that we are able to provide to practices for free that 2 years of the technology, the data interfaces, the support, the coaching, and all of that. So that's what it really means, is that we can continue to grow and do more good, which is key.
Yeah. And in the enabler market, I'm curious kind of the competitive dynamic here. I could see one world where it's kind of red ocean. Y'all are competing for the same groups and trying to have, incrementally better economics for that group, so on and so forth, tooling, et cetera, not just economics. I could see another world where it's still Blue Ocean, MSSP isn't broadly adopted yet. Y'all are going to new groups trying to get them into the program for the first time. How do you think about sales dynamic in the enabler world right now, and the mindset of PCP groups, how they're evaluating you guys versus other enablers?
Yeah. I did a road trip this year, driving back from LA to DC, stopping with practices who are prospects as well as existing clients. And I do think that the prospects are a little bit different in that they're more the mainstream rather than the early adopters, right? So when we first
Mhm.
started Aledade, the people who signed up were those who wanted to try the newest new thing. And the fact that we didn't have anything, we didn't have a track record, we didn't have any technology, we didn't have anything, was fine. And now I think the practices who want to sign up are those who want to see that it's worked, want to see a 5-year, 6-year, 10-year track record is great. And they want to see that you got your shit together, that you know what you're doing, and that the systems work together. And I think that puts a premium on people who've been doing it longer and who have a comprehensive solution with a track record. So that's in terms of the folks. We still are, I think, one of the major drivers of growth in the Medicare Shared Savings Program. More than half of our practices who are coming in have not previously been in the ACO program. And I think we have a lot of, we sign up more new practices than anybody else, but we also get more no's than anybody else. And we have some clear recommendations for policymakers in terms of the dual goals of both increasing participation in the program and increasing savings rates once you're in. And I think both are important, but both have somewhat different policy recommendations.
I'd be curious to pick up on that for a second. Like, how can you expand a little bit on
Yeah.
the differences in policy
Yeah.
recommendations from you?
So look, at the end of the day, a lot of it is about the benchmarking. And if you want people to continue to drive higher and higher savings rates, you can't essentially cap. You can't have a taxation rate that takes away almost all of that when you
Yep.
rebase. So in terms of getting higher savings rates, which 10, if you'd say, I don't know, 10% savings rate as being real savings, only 5% of ACOs not Aledade got more than 10% savings in the program. We had 25%, right? But that is a product of 2% a year savings improvement, but then rebasing takes a bunch of it away. So I think for policymakers, if you want to get higher savings rates, soften, take away, delay the rebasing. I think that's pretty obvious. Don't have us compete against ourselves. Now, one side effect of that is that the government is getting a lot more in true savings than the program savings would indicate, because the program savings obviously take away a bunch of the true savings created with the rebasing. If you want to get more people into the program, you got to address the cash flow issue. You got to give them upfront, for sure, on the barrel. My recommendation is not, upping their fee-for-service rate by 1.68% 2 years from now, but just give them $100, $200 per patient who's new to the ACO program. That will drive both expansion of bringing more people into existing practices doing ACO work, as well as bring in more practices into ACO work.
One of the articles that I was reading in 2025 that caught my attention was Milliman put out a report talking about the various financial levers for ACOs and MSSP, and they ran a bunch of simulations showing that depending on the base benchmark year, things like that, you could have swings of tens of millions of dollars at kind of the far end of performance. And it's conceptually, tracking along the space, but not being in the weeds of it. It's hard to track why there would be such a swing of performance on things that have so little to do with actual patient care. And I'd be curious, like, it it seems like the programs get very complicated and you need to spend more and more time figuring out how to administer them, which is potentially less and less time on patient care. How do you weigh that complexity? What's going on with the program from that regard? I know there are some conversations about if programs are being gamed and if ACOs should be an OSP versus ACO reach, and now it's follow-on program. Like, how do you think about all of that complexity and process for yourself?
I think it's really important for policymaking to make sure that there's true savings being created and that that's
Mhm.
better patient care. I think that's absolutely the job of good policy, is to align private profit with public good. And we are super supportive of any changes that are going to do that and are going to strengthen that. I do think, though, that if you just from even a superficial way look at the program results, people who've been in the program longer get more savings. You don't have the dynamic of people coming in with super high savings rates because you've cherry picked the people who are going to be winners in this track in this year with this whatever, and they're efficient. And then you get reversion to the mean and those savings come down over time. That's not the dynamic at all. The year one ACOs have less than 2% savings rate. And that goes up over time for us and for everybody else. It obviously goes up faster for us than for other people. But fundamentally, this program's savings are not about selection. And the average risk ratios in the program are damn close to 1.0. So while you can take that pattern matching and say, well, I know that in Medicare Advantage, there's a lot of gaming of risk scores. So it must be true in the ACO program. That is not true, right? You can say, oh, well, MedPAC says that there's selection in Medicare Advantage, so it must be true. Or ACO Reach had a benchmark that got really stale, and so there's arbitrage there, and the academic research showed that they weren't getting the savings. That's not true in the Medicare Shared Savings Program. So it's easy to misapply pattern matching, but I would just say, look at the data, look at the evidence. And the evidence shows that the savings that ACOs are getting is under-recognized compared to what they're actually saving the government. It is not the case that this is a selection and risk adjustment.
Yeah. I'd be curious that conversation with providers on the front line. Like, I imagine this, you're a provider on the front line seeing patients every day. This can feel confusing, overwhelming, hard
Well,
to understand and
yeah,
manage. What?
and
Go ahead.
I think at the end of the day, part of what the reason why you need simplifiers,
Hmm.
right, is because of the complexity. So you need people who are experts at this, right?
Yep.
Who spent their entire waking hours thinking about nothing else but how to succeed in these programs, how to get savings, what's the core things you got to do, and then can translate that into tools and data and workflows and coaching to say, here are the 10 patients, like you got 10 slots on your calendar next week, here are the 10 people to fill those slots. You don't have to understand everything about the attribution rules in the program and plurality and step 1 and step 2 and step 3, right?
Hmm.
We'll do that work
Yep.
for you, and we'll just tell you, if you want to call 10 patients in, here are the 10 sickest patients who you haven't seen in a while, who, you're going to lose attribution for. Go get them in.
Yep. So one of the things I struggle with in covering the space, there seems to be this kind of broader societal questioning of middlemen type roles, particularly in healthcare, with more and more complexity being less and less transparent and so on and so forth. And there's this desire to just simplify and make it easier for folks, getting the payments at the point of care and whatnot. How do you think about that simplicity versus complexity and the role of the middleman? And if a primary care doc is asking you, like, why do we actually need all of that? Why can't I just have, cash payments or direct pay or what have you? How do you think about that conversation?
I think for primary care, the answer is not cash pay. The answer is you got to benefit from the work you do on prevention and on reducing costs elsewhere in the system. And every primary care doc I've ever spoken to, if you said to them, do you think more and better primary care saves money over the long run, would say, yeah, of course it does. And so, like, this is our opportunity to actually turn that talk into action. But the problem with that is that if you're a primary care practice that has 100 patients or 200 or 300 or 400 Medicare patients, that's not enough to take on a total cost of care contract. So you need aggregation of risk. You need a risk pool. You need, right? Like you just have to have that, right? So then how are you going to get that? And one, and then two, you need a bunch of things, right? You need to understand the rules. You need a lawyer. You need a regulatory person. And you need scale, right? So
Yeah.
I think if you have middlemen who are doing nothing but hiding the ball and taking a cut of moving the product from A to B, right? Like PBMs or something. Now they'll arguable about whether that's the fair definition of them. That's one thing. But if you have people who are actually providing you at scale cheaper than you could go out and buy the legal and regulatory and policy and technology and data, uh, and doing it at risk with you, that's a partner. That's not a middleman. That's a partner.
Yeah.
Uh, and so I think we should be judged on the outcomes. And if we're creating more good, and we're able to do it more efficiently, then that's a good thing for society. If we're not creating good, then policy needs to address that.
Yep. Sounds- I was on the website, Alade's website the other day. There's a role posted right now, Director of Payer Strategy and Engagement, talking about how it's focused on contracting with health plans beyond MSSP, commercial, MA, Medicaid. I'd be curious how you think about expansion of those markets, goals in those markets, particularly given some of the conversation earlier about MA risk adjustment and those issues. Like, how do you process that for Alade going forward?
We didn't start in Medicare Advantage, and I think it's reflected in the amount of attention and um, focus that we put on affordability and quality versus risk adjustment. Um, because the Medicare Shared Savings Program, there was zero allowance for risk scores, and now it's capped at 3% over 5 years, and we don't hit that. So so I think it was helpful for us in not being overly torqued and not being overly impacted by things like V28, which I think uh, was necessary, right? To bring more alignment and more prioritization of the things that really matter. Um, and our practices are taking care of those patients. And my mom could be in traditional Medicare today and in MA tomorrow, and we need to be able to take care of her with the tools and the incentives and the workflows for both sides of the house. The challenge has been that unlike the Medicare Shared Savings Program, the MA program, particularly we're seeing this in the post-COVID years, has a lot more volatility than that is unaccounted for. In there's no trend adjustment the way there is with ACOs. And so we had a whole bunch of risk-taking providers, not just because of V28, but because trend was 4 percentage points higher than expected in 24, who went from making a little money to losing money on risk, not because of anything they did, but because of things outside of their control, the supplemental benefits, the pricing, the
Yep.
bids, and so forth. So I don't have to tell you this. That's been, I think, a huge challenge for the sustainability of MA-focused value-based care. And we've seen groups go bankrupt. We've seen groups drop contracts. We've seen group exit markets, and we've seen groups shrink their level of risk in that. And I think if we're going to have a continued sustainability in this partnership between payers and providers who are willing to take risk, but it should be risk that they can control. And I think we need, and one of the things we're looking for in this role, and if you are someone who's listening who would like to apply, please do, to help us craft a new kind of arrangement with payers that is truly aligning, and it relieves accountability with what we control with us and with what they control with them. And I think something as simple as a retrospective trend adjustment, which we've seen provides a huge amount of stability to the ACO programs, would be the first step in that direction.
And how about I've been hearing forever, it feels like, about VBC entering commercial market and Medicaid market to a lesser extent. How do you think about VBC's momentum in those two markets in particular? Because we always hear about it from MA perspective and V28, but we always kind of hear it burgeoning in commercial, but it never feels like it actually gains a foothold. Where's it at? How are you thinking about goals there for
Yeah,
Alade?
We have one of the largest books of commercial value-based deals in the country, over 1 million lives in commercial value-based contracts.
Mm.
And the challenge, if the challenge with MA is this prospective, percent of MLR, the heart of the problem with commercial contracts is the ratchet, where if you reduce costs, and this is something that people talked a lot about in the Medicare Shared Savings Program in the early years, and it got largely, not completely, but largely fixed, is commercial contracts often have a annual ratchet. You reduce cost of care, next year your benchmark's lower. And that's just not sustainable. And now we do have emerging a couple of commercial partners, Blues, who have what I think will be more sustainable contracts that don't ratchet or have a much softened ratchet, who give you credit back for the savings you've created and earned. And we'll see where the future holds for those.
Yeah. Want to shift over to fee for service world for a second. There's trivia obviously out in the market with the phrase it's called risk for a reason. I'd be curious how you think about working with your provider groups in both VBC fee for service. Obviously, you started in MSSP, VBC. Do you ever see yourself supporting fee for service? How do you process distinction between those two worlds?
It comes up all the time. Our practices are like, look, you're doing a great job on the value-based care side, but even in our mature practices, we've doubled their fee for service, their revenue, but fee for service is still half the revenue, right, on that patient, and it's what pays the bills today. I think there is potential opportunity there for us to help, but I don't want to kind of wake up in the morning thinking about how to maximize fee for service. I want to wake up in the morning thinking about how to keep people healthy and out of the hospital and aligned with the payers. And so I think I do think that there's a rationale for payers to say, I want this independent practice to stay independent. I want to pay them fairly, right? Not only on the VBC side, but also on the fee for service side. So they don't go join the hospital or the hospital CIN or sell to a private equity firm. And then I have to pay twice as much on the fee for service side and getting nothing for it. So I do think that it does make sense for payers over the long run, and primary care is a tiny portion of the premium dollar, right? To make sure that independent primary care docs are not disadvantaged and forced into the arms of people who are going to just be maximizing fee for service. So if we can get that sort of partnership with payers, I'm all for supporting our practices in that.
And I'd be curious. So there's the one school of belief on the cash pay DPC side of the world. There's another school of belief of let's focus more energy on fixing fee for service. VBC has failed experiment over the last 15 years. Why don't we focus our energy there? Why not take that path from your perspective?
I think it's a yes and, right? Like we got to fix the distortions in fee for service that actually keep people embedded in profit rent seeking in fee for service. So we are all for, and the value-based community has been the leading advocates, both for things like site neutral payment reform and fixing, codes that, like the skin substitutes. Like we were the ones to blow the whistle on the catheter fraud and on the skin substitutes, and to say we're on the hook and we're close to the patient, right? Not only do we have the analytics to see that the costs are going through the roof, but we also know the patients and know that this isn't necessary care. So I think value-based care providers are actually essential to reforming poor payment models in fee-for-service. But the fundamental, you are never going to get to the right price for a stroke that shouldn't have happened. Right? What's the right price for that in fee-for-service? Right? And there it does not exist in fee-for-service an incentive structure that prioritizes prevention, that prioritizes blood pressure control. Show it to me. Right? What's your solution? And I don't. It's like value-based care is like what Churchill famously said about Americans, where he said Americans always do the right thing after they've exhausted all other possibilities. and we are. I think that's where we are with value-based care. Is like we exhausted all other possibilities, and doesn't mean we don't keep working on improving the fee-for-service space, but it is not a substitute for a payment model that actually encourages prevention.
Yep. So last question for you. I know we're coming up on time. In the community this week, we're talking about this question of 15 years in, is value-based care successful? I'd be curious to hear you articulate your answer to that question, current state, and how do we know if it's being successful? Like, what are we measuring success against? And what are we looking for from value-based care as a driver of change in the system?
I think it's, they say like the future's here, it's just not evenly distributed, right? We can
Mhm.
see where it has been successful, and it's been successful in primary care, less so on the specialty side, giving primary care accountability for total cost of care. Like, it is true that all value-based care models have not worked. However, we can see that giving primary care, particularly physician-led groups, accountability for total cost of care works. And I would rather focus on the question of how do we grow that? How do we grow and make universal, where we still have only about a third of primary care in these total cost of care models? How do we make it more sustainable, more attractive? And if we can play a role in that, that's what we're here to do.
I dig it. Well, part of that, I appreciate the update on Aledade's journey. It's fun to hear the progress y'all made in MSSP. It's fun to hear how you're thinking about expansion in the MA and other categories. So thank you for the update. Best of luck on the journey. Talk to you soon.
Thanks so much, Kevin.